Hello, everyone, and welcome to today's Lunch and Learn on Facebook Live, hosted by the Center for Living Organ Donation at UHN. My name is Paula Neves, and I am the lead for the Center for Living Organ Donation, which was established in 2018 to raise awareness and improve access to living organ donation and transplantation. Today's session will focus on transplant oncology and the world-leading research taking place here at UHN that is offering new hope to patients with liver cancer. Our three speakers have a wealth of expertise on the topic and will endeavor to address all of the questions you submitted in advance and any further questions you submit via Facebook Live. We're very fortunate to be joined by two of our patient partners, Jarrett Singer and Sandra Elhilali. Jarrett and Sandra will share their personal journeys during the second half of our session. We will start with a presentation on transplant oncology and the promising research led by our first speaker, Dr. Gonzalo Sapisochin. Dr. Sapisochin is a staff hepatobiliary and transplant surgeon at Toronto General Hospital, which is part of the University Health Network. He is also an assistant professor in the Department of Surgery at the University of Toronto. He has authored over 80 publications on liver cancer, liver transplantation, and transplant oncology, and he is developing new protocols for treatment and surgical management of patients with liver cancers. And today you'll be hearing more about his work as principal investigator of groundbreaking clinical trials on liver cancer. And now, please join me in welcoming Dr. Gonzalo Sapisochin.
Thanks very much, Paula. Good afternoon, everyone. It's great to be able to join for this Center of Living Donation Lunch and Learn. So I'm very happy to be with all of you, and I hope everyone is doing well and staying safe in these times. So as Paula mentioned, we're going to talk today a little bit about transplant oncology, what transplant oncology is, and what is the research going on in this area. And actually, we're fortunately enough to have two of our patient partners that will explain a little bit about their journeys. So just a little bit about our program in general. So at UHN, we have a pretty large a very large transplant program in general, but specifically the Liver Transplant Center is a very large program. We're the largest liver transplant program in Canada. We have very good patient outcomes when we compare ourselves to other programs, in the country or even abroad. When we compare our results to data from the US, for example. We've done almost 4,000 adult liver transplants since 1985, and we perform around 200 transplants per year. We're one of the largest liver transplant programs actually in the world, and for sure in North America. We've done almost 900 living donor liver transplants since the year 2000, and we follow up care for over 2,000 patients. So it's a huge team and a huge effort to follow up all these patients. We have a good track of groundbreaking research, advances in science, and improving care of patients in the transplant field. And we're compassionate experts in working very hard to achieve the best possible outcomes. So what is transplant oncology, and why we think it's an important field in medicine? So we know that for most of the solid cancers that can happen, in this case in the abdomen, but also in other organs, the only curative treatment is surgical removal, and we know this from again most cancers, colon cancer, liver cancer, etc. Usually there's a combination of some chemotherapy agents and surgery, but we know that surgery has been shown in most studies is the only option to cure. I'm both a liver surgeon and a liver transplant surgeon, so I do a lot of hepatobiliary surgery of the liver and the bile ducts, and also transplants. And as liver surgeons, we can perform very advanced resections of the liver. We can actually remove up to 70% of a human's liver. And this is thanks to liver regeneration, which is actually a fascinating thing that the liver has. And this is an image from Prometheus. This is the myth of Prometheus. Already the Greeks knew that this was the case. And this is, Prometheus was punished by an eagle coming every night to eat, his liver, because the Greeks already knew that the liver would regenerate. So this has been known for a long time, and it's actually absolutely fascinating. The problem is that in many cases, where there's cancer in the liver surgery is not possible, and this is because the liver is too sick to undergo a big operation. Like, this happens mainly in cirrhotics. Maybe 20%, 25% of the liver is not spared for the disease, and there's other conditions, and therefore surgery can't be offered in these patients. So one can think, well, if surgery is the only treatment, but we can't spare 25%, or we can't remove the tumor, what about transplanting this organ, basically taking the whole liver out and transplanting a new organ in, because obviously one can't live without a liver. And this is the concept of transplant oncology. And transplant oncology actually is a discipline where there's a lot of participants, and there's different teams that work together to make this happen. And obviously there's surgical oncologists like myself. There's oncologists, and these are radiation oncologists, medical oncologists that are the doctors that are going to help with chemotherapy or radiotherapy before or after the transplant. Obviously the transplant team, and that's where there's the interface of some of us that are both surgical oncologists and transplant surgeons. And then obviously there's a lot of other disciplines that participate, like radiology, pathology, genomics, and many others. And all this is what constitutes transplant oncology. Transplant oncology has evolved a lot over time. From a historical perspective, it's very interesting to know that the first liver transplants that were performed in the 60s by Thomas Starzl in Pittsburgh were actually tried in patients with cancer. That was the main indication. They wanted to cure these people, and they didn't know how. So they tried to do liver transplants in patients with different cancers, and the outcomes were very, very poor for many reasons that I will explain later. But basically, patient selection, there was no help of these multidisciplinary teams. These were surgeons saying, well, I have this patient, I need to help this patient, how am I going to do it? Since 1996 is probably the first study from Vincenzo Mazzaferro, who's is one of my mentors and a good collaborator, who designed the Milan criteria, which was a way to deciding which patients were going to do well with a liver transplant for primary liver cancer, for hepatocellular carcinoma. And from there, there's been a lot of evolution for, the study from the Mayo Clinic that we'll briefly discuss for liver transplantation for cancer of the bile ducts, liver transplantation for metastases for neuroendocrine tumors, liver transplantation for colorectal liver metastases that we'll talk a little bit later, the work we've done in intrahepatic cholangiocarcinoma. And all this is moving really, really fast in the last 5 to 10 years. And as you all know, there's a lot of advancements in genomics, a lot of advancements in chemotherapy agents, a lot of advancements in artificial intelligence, and all of this is getting together to really advance the field in transplant oncology. And as I mentioned, why is there a new era? Why this was tried in the past and it didn't work, and now it seems that, there's a new era and actually we're able to help a lot of patients? Well, I think there's, mainly 5 reasons. There's probably more, but these are the main reasons. I think one is that there's been a lot of improvements in systemic therapy. So there's been huge improvements in colon cancer systemic therapies in the last 15 years. There's been a lot of advancements in chemotherapy agents for cholangiocarcinoma. We're having, there's a huge revolution in the treatment of hepatocellular carcinoma with immune therapies. There just was a positive trial that just came out in New England. So this is all really, really changing. Also, we have an increased availability of donor organs. We still don't have organs for everyone, but certainly we've been able to increase the donor pool by doing living donor liver transplants, by splitting livers, and by finding other ways of using organs. As you probably know, another big revolution in medicine has been the treatment of hepatitis C. Patients with hepatitis C didn't have a treatment before, and mainly they develop cirrhosis and end up needing a liver transplant. And in the last 10 years, there's a huge new amount of drugs that have come out that actually cure hepatitis C. And actually, every jurisdiction in the world is seeing that there's less patients that need a transplant for decompensated hepatitis C. And, here in North America, it's slightly different because we have the, fatty liver epidemia. But there's many programs in Europe, and some of you know, but I'm from Spain, and there's programs that don't have a waiting list anymore. So there's a lot of people already thinking, well, we need to find a way of utilizing these livers, and one is transplant oncology. I think the other reason is that, as I talking about history, when Starzl started to do these transplants, the post-transplant mortality was super high. They were learning how to do transplants. Nowadays, the survival is very high. Most patients stay in hospital for a week, and actually, the outcomes are very good with liver transplant. And finally, we've learned very well how to manage the immunosuppression in these patients. We're not that worried about rejection as we were 15 years ago, and we're able to try and minimize the immunosuppression in these patients in a way to balance rejection and the risk of having a too diminished immune system. So which cancers can benefit from liver transplant? Obviously, this is not for every cancer, and this is not for every patient. And this is mainly for cancers that are confined to the liver. So these are going to be, hepatocellular carcinoma. So this is primary liver cancer. This is cancer that grows in the hepatocytes, and it's typical of patients with cirrhosis. Intrahepatic cholangiocarcinoma, which is a cancer that grows in the bile ducts inside the liver, but grows from the bile duct, so it's a different cell. And this can happen both in patients that have cirrhosis and patients that have a totally healthy liver and don't have cirrhosis. The other type of biliary cancer, so cancer that grows in the bile duct, is the hilar cholangiocarcinoma, which is a cancer that instead of growing in the periphery of the liver, it actually grows in the bifurcation of the bile ducts. The bile ducts drain all the bile into the bowel, and that's where this kind of cholangiocarcinoma grows. And it's typical of patients that have a kind of liver disease called primary sclerosing cholangitis, which is an inflammation of these bile ducts, and they develop these kind of cancers. But it can also happen in patients that don't have primary sclerosing cholangitis. And the other indication that we'll talk about is disease that actually metastasized from to the liver from a different organ. And this is mainly neuroendocrine tumors, when basically the disease from the liver is coming from a neuroendocrine tumor that has grown in the abdomen, and colorectal cancer liver metastasis, as we'll talk a little bit more in detail. I think it's important to mention that this is all only, as you can imagine, in patients that have disease confined to the liver. Obviously, if there's disease outside of the liver, a transplant, unfortunately, in that case, is not going to help. Obviously, one of the problems we have with liver transplant, as I briefly mentioned, is that there is a disbalance between the amount of patients that need a transplant and the amount of donors, right? And this is well known. This is a reality, in places like Canada. I told you places like Spain, where the rate of donation is very high, and now they're starting to have a very short waiting time. Actually, in places like us, there's still a huge disbalance, and this is true for the US and for many other jurisdictions. So obviously, one needs to decide on the available organs, who is going to do best, and try and allocate organs with the concept of transplant benefit, of what's going to be an adequate outcome. So we can't transplant everyone. And usually what we've, the transplant community has come on an agreement is that the 5-year survival when we transplant a patient with cancer should be the same as if it's a patient without cancer. And that is usually around 50 to 60% 5-year survival, meaning at 5 years, 60% of the patients need to be alive. Now, there's a very interesting concept, and is what happens if someone has a living donor and it's not competing with someone in the waiting list, right? Because someone that donates part of the liver actually is giving 2 livers. It's giving a liver to that person, but it's actually taking a patient out of the waiting list. And obviously, when someone comes with a donor willing to donate, it's very uncertain what should be the 5-year survival when there's going to be any benefit. And this is this is an ethical question that actually no one has a real answer. So going on to talk a little bit about the cancers we do transplant. So the most frequent cancer we transplant is hepatocellular carcinoma. This is primary cancer of the liver. This is cancer that grows in the hepatocytes. And as you can see, this is data from our own program at UHN. There is a huge proportion of patients that currently we are transplanting for cancer, and that we have transplanting for the last 10, 15 years. And as you can see in this plot, 40% of the patients we transplant nowadays are patients that have hepatocellular carcinoma. So this is not something that is uncommon. Like transplanting patients for cancer, at least for hepatocellular carcinoma, is something that we do routinely. It's important to mention that liver transplant represents the best treatment for liver cancer. It's been shown in many, many studies. There's no real discussion about this. And the reason is because a liver transplant treats both the cancer and the underlying liver disease. And the underlying liver disease is the main risk or the main ground where new cancers develop. So if we're able to remove the liver with the pro-oncogenic tissue, which is the cirrhosis with the cancer, that offers the best chance of cure. However, candidates for liver transplant for hepatocellular carcinoma can be only those, again, that don't have spread outside of the liver, so there can't be disease outside of the liver. There can't be invasion of major vessels, and that is because we know that if the vessels are involved, probably there's already spread outside of the liver. There can't be widespread of cancer in the liver, and the tumor marker has to be low. And again, that is a sign, it's a biomarker that if it's very high, it's telling us that probably there's disease outside of the liver. I think it's very important to mention that the survival of patients that get a liver transplant for hepatocellular carcinoma is actually remarkable. These are patients that, the chances of being alive 5 and 10 years after transplant are 75 and 60%. When you compare these outcomes with surgery, removal of other abdominal cancers like pancreas cancer or resection, surgery, removal of a cholangiocarcinoma, the outcomes are much, much higher. So having a 60% 10-year survival for a patient with multiple liver cancers is actually an amazing outcome. And the risk of the cancer coming back is actually pretty low. 80 to 85% of our patients remain cancer-free. This is after the transplant. So moving on to what is a different type of cancer and where there's a lot of research going on, it's the biliary cancer. So again, this is cancer that grows in the bile ducts, again, as I mentioned, in these tubes, these green tubes you can see in this diagram that drain all the bile into the bowel. And there can be, as I mentioned briefly, different types of cholangiocarcinoma. So as you can see, A is the intrahepatic cholangiocarcinoma, is the one that grows really, peripheral in the liver. There's the Klatskin, what we call Klatskin. The Klatskin was a German surgeon and pathologist that discovered this tumor, and it's a tumor that grows in the bifurcation, as you can see, of the bile ducts, where the bile ducts bifurcate between the right and the left. And then there's the distal cholangiocarcinoma, which affects mainly the pancreas, and we won't talk about today. So what's going on in terms of transplant for these cancers? Well, if we talk first about hilar cholangiocarcinoma, again, the one that grows in the bifurcation of the bile ducts, for many years, this was not an indication for transplant, and data from mainly the Mayo Clinic came out probably now 15 years ago, showing that actually if you treat patients very intensively with chemotherapy and radiation before the transplant, and you're able to transplant them, the chances of these patients being alive 5 years is around 75%. So again, these are patients that without a surgical treatment, they don't survive a year. Like on chemotherapy and radiotherapy, the median survival is around 11 months. So again, we're talking about a very good treatment for a pretty devastating cancer. The outcomes of this treatment or for transplant for hilar cholangiocarcinoma is best in patients that have primary sclerosing cholangitis compared to those that develop de novo on totally healthy livers, develop de novo cancers, and probably is because of the timing of diagnosis. It's important to mention that transplantation for hilar cholangiocarcinoma in Canada is only done at UHN, and we get patients from all around the country that come here to have this treatment with chemotherapy, radiation, and then get a transplant. And again, this is a clear example of transplant oncology where there's a lot of different people involved. These people see, a surgical oncologist and a transplant surgeon like me. They see the radiation oncologist, they see the medical oncologist, then they see the transplant hepatologist. So it's really a teamwork that puts together this concept of transplant oncology. Moving on to intrahepatic cholangiocarcinoma, again, these are tumors that grow on the bile ducts but peripherally. This right now is investigational. I have led several studies, multi-center studies around the world showing that in patients that are cirrhotic, so patients that have liver disease, if you're able to transplant patients with early disease, these are small tumors, actually the survival is very, very good. And the reason this is important is because until now, this was a formal contraindication for transplant. So if a patient with cirrhosis came to my office and had a tumor that looked like cholangiocarcinoma, we did a biopsy and we confirmed this is cholangiocarcinoma, they were excluded from transplant. And now we have a multi-center trial where we're investigating prospectively the outcomes of these patients with a transplant. The other idea, or the other population that can be benefit from transplant, is that population of patients that have a healthy liver and unfortunately develop this large, big intrahepatic cholangiocarcinoma in the liver that in many cases are multifocal. Unfortunately, this usually happens in young people, and there's no treatment option. And as I mentioned, the median survival on chemotherapy, which is the standard of care, is 11 months. Again, with some data that came from MD Anderson and a group in Texas, with a very limited number of patients, they were able to show that treating these patients with chemotherapy for at least 6 months and having real stability on chemotherapy, and then transplanting these patients because they couldn't do surgery, going back to my first slide about surgery, they couldn't resect these patients. Actually, the survival after transplant was very good. Still, the risk of the tumors coming back was high, but again, the benefit these patients got was pretty good compared to chemotherapy. Now, that was a very small study, so we are actually doing a prospective trial, trying to investigate this and trying to include more patients and see if we can actually prove, which I think is a reality, that these patients are going to do better with a transplant than without it. So I'm going to move to the metastatic setting, and due to time, we're not going to talk too much about neuroendocrine tumor metastasis, but I wanted to focus on colorectal liver metastasis. So as you know, there's a lot of patients that unfortunately still are diagnosed with colon cancer. Colon cancer is still pretty prevalent all around the world, but especially in Canada. And 50% of the patients that develop colon cancer are going to develop liver metastasis at some point. And the reason being is because all the drainage of blood from the colon goes directly to the liver, and the liver is like a sponge. The liver has a lot of immune cells, etc., that are going to suck up these metastases, and it's very frequent. As I mentioned, 50% of the patients are going to develop liver metastasis. So this is spread from the colon or rectal cancer into the liver. Now, there's many studies that have shown that the only potential for cure of stage 4 colon cancer when there's only metastasis to the liver is surgery. And it's a combination of chemotherapy and surgery. And this is an example of all the different operations we're able to do. So as you can see, on the left side of your screen, you can see that all those black dots are metastases. And for example, in the first column, this thing that says PSH is what we call, or what I call, the Swiss cheese technique, and is when there's many metastases in the liver and we're actually able to take them all out, right? And you can see all those holes. Then you can actually remove, as I said at the beginning, you can remove a whole lobe of the liver and then do metastasectomies of these metastases and leave the patient with 40%. You can do 2-stage hepatectomy, where you do a first operation and then you do a second operation and remove 75% of the liver. You can do many things. The problem becomes on the right-hand side of your screen when all the metastases are affecting all the liver and they're deep in the liver and you can't take them out. And here's where transplant may have a benefit for these patients. Now, obviously, the question is who is eligible, and not everyone is eligible for this, obviously. And here's a diagram that my colleague, one of my colleagues from Oslo, and I'll talk a little bit about him, just published in a very interesting review. And as you can see, there's a large population of patients with colorectal cancer. 50% are going to develop metastases. Of those 30 to 50%, there's going to be only disease in the liver. 70% of those, so imagine 70% of patients with bilateral metastases, we can't offer them surgery. So their only treatment is palliative chemotherapy. And of that, 10% fulfill a strict criteria, and 1 or 2% of that big pool are actually end up being candidates for transplant. So this is for a very selected population at this time. And who is eligible? Well, are patients that have a primary colon cancer that has been resected at least 6 months before we can assess them. As I've been mentioning all around my talk, these are patients that have only disease in the liver, so we can't assess, or we can't transplant a patient that has lymph node metastasis in the porta, or there's distant metastasis in the lungs, because we're not going to help them, as you can imagine, with a liver transplant. they have to be very stable on chemotherapy for at least 6 months, and that's a marker of good biology. And we know this, in depth from the literature from resection. We don't transplant patients with BRAF mutation, and that's because the outcomes are really, really poor. But we do transplant patients that have KRAS, obviously mutant variations. Again, this is a photo of when, Dr. Paldak, who's the chair of the Department of Surgery in Oslo, visited us. He's a very good friend of mine. He was here actually just before COVID stopped all the traveling. He was here at the end of January, and we had fascinating conversations with him. We actually, improved our protocol, and we actually, as I show you later, working on a large scale registry. But, in terms of the outcomes, all the data right now is coming from Oslo. They have been the pioneers, and the reason they've been the pioneers, besides having him and being a very accomplished team, is that they have a very interesting problem in Oslo, and it's that they have more livers than patients that need a liver. So they don't have this problem of a waiting list. So, they started saying, well, we have these patients that we can't operate. The only way to cure these people is to take the whole liver out. And actually, they started this back in 2010. Their first outcomes were already very good with 15 patients that had a 5-year survival of 60%. However, the recurrence was very high. But still, they came with the concept, and this is a concept very well known in oncology, is that you reset the clock. So you take all the disease out, and even if we know that the recurrence was going to come back, patients still had a 5-year survival of 60%. And just to put it in perspective, if we compare with standard of care, which is palliative chemotherapy, the 5-year survival is probably close to 5 to 10%. They've actually published new results. They've refined their criteria. The 5-year survival still remains. They have 10-year survivors now, and the recurrence rate they've been able to reduce to around 60%. So it's still high, but again, the outcomes are very good. And the reason the outcomes are good, even though there's recurrence, is because they're very aggressive in treating recurrences. So if a patient develops a lung nodule a year after transplant, they would be very aggressive resecting it. They would be very aggressive with chemotherapy. And they've actually published a bunch of studies showing the world all this. So what's the current status of liver transplantation for colorectal liver metastases? So right now it's investigational. We are still in the process of making it standard of care, and that's going to take a while. And as you can see, there are several trials going around the world, mostly in Norway. As you can see in this slide, 3 of these are basically their trials in Norway. We have a trial here in Toronto. There's a trial going on in France. There's a small study going on in Germany, one in Sweden, and one in Italy. And one of the things we've developed and we've just about to launch with the help of a couple of societies, both the International Hepatobiliary Association and the International Liver Transplant Society, and this is led by us, Paldak from Oslo and Rochester, is an international registry, because everyone is going to have 2, 3, 5, 10 patients. It's going to be very important to have all the patients in a registry and be able to analyze this in detail so we can learn and we can offer this treatment in the best way to our patients. So finally, I wanted to discuss a little bit with all of you about the pathways. How do we get to a liver transplant? And I've already briefly alluded to this, but I think it's important to show you that obviously there's disease organ donation and there's living donor organ donation. And this map can already tell you that obviously the route of disease organ donation is a very good one. But in countries like Canada, where there's still more patients in the waiting list than patients than available organs, the wait is pretty long. And obviously with a living donor organ, the wait is shorter. It's not, we can't do it tomorrow, but obviously things move relatively faster. We are the largest live donor liver transplant program in the Western world. We've been doing this since the year 2000. Just to put it in perspective, we do around 60 to 70 live donors every year. And, the largest program, now there's a program in the US that does a little bit more around the 50, but transplants or live donors per year. But normally the programs in the US do like 10, 15. So just to put it in perspective, there's obviously very large programs in Asia where they don't have disease donation. And many of us have gone there to learn. But we're the largest program in the Western world, certainly in North America and in Europe. around 25 to 35% of the transplants we do are living donors, and we mainly do right lobe, meaning we remove the right lobe of the donor, which usually represents around 60% to 70% of the liver. And as I mentioned before, the liver regenerates. You know, we need to work around 3 to 4 donors until we actually find a good match, and this is because we need to make sure all the vessels are adequate. The only match that has to be between donor and recipient is the blood type. We've had 0 mortality in our program, and we have less than 5% major complications. And as I said, you know, donors go back to normal life very, very soon, and usually with no limitations or restrictions. We haven't had any long-term problem. And what is the rationale behind doing living donation? Well, I've already briefly alluded, but this is just to show you some data from our own program. And in the left of your screen, you can see all the patients that get listed every year in our program. And in gray is the terrible outcome when a patient never gets to transplant and dies before getting a transplant. And this means the patient got too sick, or in our case of transplant oncology, actually the tumor progressed and we didn't get on time. Now, specifically for liver cancer, for hepatocellular carcinoma, on the right of the slide, you can see that in red, you can see all the patients that every year progress, and because they were waiting for a liver transplant. And we know that 25 to 30% of the patients that are waiting for a liver transplant in Toronto never make it to a transplant. And this is very similar in several jurisdictions around the world. And this is where living donation, when a relative, a friend, someone from your circle can help to try and avoid this. Obviously, the most important thing when we do living donation is donor safety. That is our #1 priority. Donors are, very altruistic people that, step forward to help others, friend, family member. So we take special care of everyone, but the donors, donor safety is something that we're very serious about, obviously. And this is data that we published some years ago that shows that, the line on the top is the number of living donor liver transplants we've been doing during the years. There's been up and downs, but as you can see, in terms of adult living donors, it's around the 40 to 50. And as you can see, the bigger line is any kind of complication. This includes a urinary infection, like a very minor complication. We collect all the data, obviously, and a major complication, like a patient that bleeds or need to go, it's pretty low. It's around the 3% mark, and it's been very stable around the years. So how are you eligible, and what is the process to become a living donor? Well, living donors are usually patients, or not patients. They're actually people that step forward that are between 16 and 60 years old. They have to be in excellent physical and emotional health. They have to have a normal liver function. The liver usually is perfect. They have to have, obviously, support from family, friends, and primary care. It has to be a voluntary choice. We have separate recipient and liver donor teams in keeping with our best practice. I actually participate in both, but I never would be involved in the donation process of one of my patients. We totally separate that. And one donor is assessed at a time. So if someone shows up with 7 donors, well, we assess one donor, we make sure that donor is eligible or not, then we assess the next one, just in keeping with our best practices. The donor surgery is a big operation. We're very well trained to do this operation, but it's an operation that takes around 7 hours. And donors usually stay in hospital between 5 to 7 days. The majority of donors return to work within 6 to 8 weeks. And I always like to, and she's happy for me to share this, but I have a very good friend who's a cyclist like me and cycles in my cycling group. And, she donated a year ago. And she was in a trip in Spain cycling for a week, the week before donating. She went on to donate, kind of 4 days we came back. And 4 weeks later, she was at 5 a.m. riding with me in the street. So, and she's back to normal. And actually 3 months after donating, she did a 200-kilometer race with me in September. So donors usually come back to absolutely normal life and health. So in terms of how to become a living donor, in terms of practicalities, we have a website dedicated to this. There's a complete donor health history form, and that's kind of the first step to make sure we can assess you as a donor. There has to be a submitted, completed form along with a copy of the blood type, as I mentioned, with a family doctor or blood donor card. And then we have a specific office and a living donor coordinator that can start all the process. And then you can book a call with the Center for Living Organ Donation and sign up for online classes. We have lots of teaching, lots of videos, and a lot of information, and all of information is needed in that regards. In terms of what we're doing, and just to finalize my talk, we're doing a lot of research here at UHN on transplant oncology. I'm very passionate about it. I think it's a fascinating field that combines a lot of different specialties, a lot of different research idea. As I explained you briefly, we are very active on doing clinical trials with new indication, but we're also working on biomarkers on how to identify which patients are going to do better, which patients are going to do worse. We work with a lot of other principal investigators. We're, for example, currently looking on radiomics, and this is a science that we can look at how a tumor looks on a CT scan and take out with artificial intelligence like the marker of that tumor, and then predict which patients are going to do well or better. We're taking samples of every tumor, and we're doing genomics of these tumors to learn more about them. We're taking blood of every patient, and then we can serially see, analyze, and do liquid biopsy, which probably will help in the future. We're working a lot on neoadjuvant therapies in hepatocellular carcinoma. As I mentioned, it's a fascinating moment for hepatocellular carcinoma. Immunotherapy is really being a revolution. So we're working on trying to find ways of treating patients while they're waiting to make sure that we can drop that risk of the patients progressing while they're waiting, and actually maybe improve their outcomes after transplant. And then if the cancer comes back after transplant, we're also trying to find ways of how we can treat that better if that happens. So I'm going to let Paula introduce our patient partners. I mean, she's introduced them already, but to get them to explain their experience. And thanks again, everyone, to be here. And I would like to also thank Courtney and Paula to organize this.
Thank you, Dr. Sapisochin, and thank you for a very comprehensive review of transplant oncology and the vital role it's playing in hard-to-treat liver cancers. I know many in our Facebook Live audience have questions for you, so please keep them coming, and we'll try our best to address them all during the Q&A portion of this event. I would now like to invite our patient partners, Jarrett Singer and Sandra Elhilali, to share their inspiring stories. We'll start with Jarrett and then invite Sandra to talk about her journey. Jarrett?
All right, thank you. So as Paula said, my name is Jarrett Singer. I'm currently 20 years old, and I was diagnosed with liver cancer in December of 2018. I noticed something was a little bit off with me around November. I was just doing my first semester at university, University of Guelph, and I started to notice that I wasn't feeling quite right. I was dealing with some abdominal discomfort. I was overly exhausted. I was sleeping 14, 15 hours a day, sleeping through alarms and classes. And then around early December, I started to have some really bad abdominal pain, acid reflux. And so after my semester was over, I decided to go back to my family doctor at home and to just get it checked out, see what it was. And so they recommended an ultrasound, and through that ultrasound, they discovered that there was a large tumor in my liver. So on December 23rd was when I was first told that I had it. And after that, I was referred to Toronto at UHN to have a lot of testing done. So MRIs, ultrasound, CTs, colonoscopies, basically everything under the sun to try and see what this was. I had a biopsy, and it turned out that my specific liver cancer is quite rare. It's about 1 in 5 million people get this type, so it's quite uncommon. Not a ton of research and knowledge on it, so for me that was quite nerve-wracking. I didn't know what to expect, considering that, like I said, it's quite uncommon. So the first attempt to try and get rid of it was in February, where they wanted to do a resection just to take a portion out, but through that procedure, they found that it wouldn't be possible based on location. It was blocking too many vital areas, and they thought it'd be more risky to do it than to not do it and find another way. After that point in time, they suggested that my family and I should start looking for a living donation. So we put the word out. We used platforms like Facebook, Twitter, and just posted asking for people to sign up. And to my surprise and to my gratitude, over 100 people put in their name for me to sign up as living donors. Throughout that time, they wanted to try a different procedure to try and shrink the tumor, or at least kill some of it, slow the growth, so that I'd be able to go through with the living transplant. So they wanted to try an yttrium-90 Y90 treatment, which is a chemotherapy that is injected directly into the liver through the femoral artery in the leg. But because of how large it had grown, they realized that going ahead with the procedure would maybe cause more damage than benefit. So they decided to go with a different treatment, TACE chemotherapy, which was unknown if that would work. And to my, again, gratitude and surprise, it not only killed some of the tumor, but slowed its growth significantly, which then allowed me to go ahead with the living transplant. And in May 13th of 2019, I had my transplant, and I'm currently 1 year cancer-free.
Thank you, Jarrett. Sandra?
Hi, everyone. Our story begins after a visit to the ER on Mother's Day of 2017, when I was 42. In truth, our journey started several months before, when I started experiencing fatigue and a sharp pain on my right side. Our family physician ran a series of tests, which all came back normal, apart from some iron deficiency anemia, which helped explain some of the extreme tiredness that I was experiencing. I was told at that time that it was a picture of health and not to worry. Unfortunately, my health started to rapidly decline, and I had all but stopped eating by then and was sleeping most of the day. I'm no longer able to do the things that I loved with the people that I love. A visit to our local clinic resulted in a referral for a colonoscopy to rule out colon cancer. At the time, I thought it was odd, as we have no family history. I was quite young and lived a very healthy lifestyle. I reluctantly went for my scope and was told that there was a chance that I possibly had colon cancer. A few days later, on the morning of Mother's Day, a day that I typically spend with my family at the lake, I ended up visiting the ER, where we soon found out the situation was far more serious than any of us could have imagined. It totally took everyone by surprise. I was diagnosed later that evening with stage 4 colon cancer with metastases to the liver. My husband and I were still reeling from the untimely passing of my dear father-in-law, Dr. Mustafa Elhilali, who was a leader in the field of urology, a man that had achieved many honors during his career, including the Officer of the Order of Canada. So in addition to experiencing this loss, coupled with the devastating news, we realized how much we missed him and wished that Dad was with us to help us navigate this part of our journey. We were in complete disbelief as to how this could have possibly happened. I was, of course, holding out hope that perhaps they had it all wrong. Our CT scans, however, painted a very different picture. And I'll never forget the radiologist who sat with me late in the hours that evening, counting up my metastases on my liver. And when we reached 20, we both took pause, realizing that there was really no need to continue. Our diagnosis was very real and profoundly serious. I was immediately admitted that day and quickly learned that I would be receiving chemo in a palliative setting with the possibility of not being able to return home to my family. It was the absolute worst possible scenario, but we were determined that somehow we were going to beat the odds and that Dad was helping us, leading the way. This was, however, going to require a lot of effort and importantly was going to require a group of forward-thinking individuals willing to take on an insurmountable challenge, like people like Dr. Sapisochin at UHN. Almost immediately, I was started on chemo. Our second set of tests gave us the hopes we were all desperate for. My CEA had dropped drastically to 284 from 6,082, which is quite high. And my primary colon tumor was no longer visible. My liver, however, still resembled a spotted Dalmatian. That's what it looked like to me at the time. And we were very fortunate to have such a positive response, and our odds of having a longer life expectancy outside of the 6 months I was given was starting to look favorable. Right around this time, one of Dad's peers at Sunnybrook reached out to us, letting us know of a clinical trial at Sunnybrook for hepatic arterial infusion chemo, where I would be receiving directed chemotherapy directly to my liver, in addition to systemic chemo. In October of 2017, I underwent a resection of my colon, received my pump in hopes of getting to a surgical liver resection. And for many months following, I was receiving both, and our CA was continuing to come down, but we were seeing very little change in my liver, but disease remained stable. At this time, we were still hopeful that we were going to beat the odds. But it was becoming increasingly apparent that we were going to need some help, and we would have to look at an alternative solution. It was right around this time that we started looking at liver transplantation, a clinical trial that was being held at UHN. In June of 2018, my husband and I had the honor of meeting with Dr. Sapisochin and learning about the tremendous work he was doing at UHN. He discussed with us the possibility of a liver transplant and all that it would entail, and patiently answered all of the many, many questions that I came with. I am forever grateful for the time that he takes in addressing our concerns, and I came away from that meeting with a renewed sense of hope, knowing that if I had to entrust my life to anyone's hands, I could not ask for a safer place in which to place it. Now came the tricky part. We had to ensure that our cancer remained stable and that disease didn't spread to other organs while we waited to find our living donor. Once we let our immediate family know that we needed a living donor, news spread quite quickly. I was completely overwhelmed by the positive response, and especially moved by individuals that I had not seen or heard from in many years, and some who I barely knew who came forward. I had no idea how our simple existence had touched the lives of others, and I would not wish this on anyone, but there's something to be said about being witness to people's generosity and willingness to put their lives on the line for someone else like me. The period between October 2018 and February of 2019 was filled with highs and lows. We cheered for those donors who made it into the evaluation process, and also lived through their heartache when they learned that they were not a successful candidate for us. For me, it was also very challenging to accept the risk for these patients, and felt an enormous responsibility for our potential living donors. In March of 2019, after months of waiting to find a matching living donor, in a crowded airport in Jamaica, I received a text from my cousin that would forever change the trajectory of our lives. It read, "My Kate is at the cleaners getting ready for our big day." I can only imagine what people were thinking as they looked upon my daughter and I in an embrace at the airport with tears streaming down our face. It was one of the happiest moments of my life. A little over a year ago, my first cousin and earthly bound guardian angel, George, saved my life for a second time when he donated his right lobe of his liver to me. For more than 12 hours, a skilled and devoted team of surgeons and nurses at Toronto General worked tirelessly to keep our donor safe while saving my life. And on May 1st, I was officially the second liver transplant recipient for stage 4 metastatic colorectal cancer in Canada. This unique rarity of a gift is not lost on me, for there has always been an underpinning desire to not merely survive, but to thrive. This incredible gift allows me to continue in being a wife, a mother, a good friend, and a patient advocate. I am forever grateful and blessed for this second chance at life, and every moment that I get to spend with my children, sharing adventures, seeing the world, or just sharing simple moments is a gift that I will cherish forever. Thank you.
Thank you, Sandra. As I was listening to both your stories, I could hear how heart-wrenching it was to get a diagnosis and the ups and downs of your journey, and how fortunate we are to hear that it was successful and that you remain cancer-free. So thank you very much for sharing your stories. We've now reached the Q&A portion of today's session, and so if you have questions, please submit them via Facebook Live, and Courtney Mart, who handles communications and social media for the center, will read them out. In the meantime, I will ask Dr. Sapisochin to address questions submitted in advance that we did not get a chance to answer during the formal part of this presentation. So I'll now turn it over to Dr. Sapisochin.
Thank you very much, Paula. Thanks, Sandra and Jarrett. That was fantastic how you were able to share your experience. Thanks for being with us today. So these are some of the questions we received. So I will try to assess them as we go, and please submit your questions. And I guess we have still 10 minutes, so hopefully we'll be able to answer any other questions that may arise. So one of the first questions, is what are the next steps with your research and then there's a second question related, which is what are the roadblocks we anticipate in implementing this in routine practice. So in terms of research, I briefly explained, I think the trials are very important, and, we're, again, developing, as I mentioned, new indications for transplant oncology. I think I feel it's very important to work in a collaborative way, not only here at UHN, but internationally. So that's something we are working very hard on. I think it's very important that people from all around the world try and work together in this idea. So in that regards, I mentioned briefly, but the International Liver Transplant Society also has a special interest group on transplant oncology that I lead. And I think that's important to develop trials. We have conference calls and we discuss different research. I think the other big portion is all the translational research that we can do with the help of other PIs or principal investigators. I think the liquid biopsy is something that is going to be important in all this arena. I think genomics is something that we're doing more and more and trying to learn. And I think trials investigating drugs in this arena or in this scenario, I think are going to be very important, because we're going to have it's going to be a very good platform to one, to test how these drugs can work, but especially to increase the number of patients that we can actually offer a transplant. I mean, roadblocks in the routine practice of these trials, there are many. One that is actually we're still working. I mean, when we launched this trial, I actually gave talks, all around the province in different cancer centers. I think, unfortunately, there's a lot of patients that still don't know that this exists, and they're still treated on palliative chemotherapy. And, Jarrett and Sandra are advocates for our program and are very important for this. And I think it's important to have the word out that, these patients may have a treatment option. Obviously, as I mentioned, always when the disease is in the liver. But I think that is a little bit of important to explain to other cancer programs and other cancer doctors that this exists, and to be able to offer it to our patients. In terms of the next question that came up is what happens after the transplant and what is the daily protocol. I think I guess this question, I'll generalize it in terms of after transplant in general. The postoperative course of a transplant, again, it could be, a little bit long. It's a very big operation. But, usually patients that are transplanted for cancer, their liver is not very sick to start with. So usually patients stay in hospital for a week to 10 days. There can be lots of complications, but in general, again, it's a procedure it's well tolerated. Obviously, all patients need to be treated with immunosuppression. These are drugs that are going to decrease your immune system so your liver doesn't reject. And that's where, with our transplant hepatologists, and again, emphasizing on the multidisciplinary nature of this of transplant oncology, we work on trying to give drugs that may have some anti-cancer effect at the same time that they immunosuppress your body to avoid rejection. And that is kind of the daily protocol for the beginning. But to be honest, again, and you've seen two examples, like once the months have passed, like actually life goes back to almost normal. In terms of good candidate for this procedure, I'm going to briefly mention and what eliminates you from being a candidate. I think I described it a bit on my talk, but I think it's very important, again, to mention that this is disease inside the liver. There can be spread outside. And then it's important to say that there's some criteria in terms of size of the tumors that I didn't want to get in detail, but depending on the tumor, we do have some criteria that we'll have to analyze when we see the patients. The next question is, could a living be a half sibling, and do you just take part of the liver and grow it inside me? So the question is, yes, anyone can be a donor for your transplant. It's someone that has to come from your circle of friends or known or family members. So we can't provide you a living donor. So it's something that has to come from you, but it can be anyone from your circle of friends. We do. So on the recipient, on the person that has the cancer, we do remove the whole liver, and we do transplant part of the liver. Usually, as I mentioned, it's around 60 to 70% of the donor's liver, and both in the donor and in the recipient, the liver grows as much as it needs. So that will answer that question. The next question is, are patients who have experienced a recurrence to the liver alone eligible for our trials, and have other liver transplants for colorectal cancer clinical trials, just as Oslo included these patients, and what are the outcomes? So the answer is yes. At the beginning, we were cautious on not to include these patients, but getting lots of discussions with the Oslo team, we do include these patients. It's actually, from a cancer biological perspective, it actually makes sense that if you're able to resect a cancer that only grows in the liver, and for years it only grows in the liver, that's a good sign that probably there's no disease outside. So we do include those patients. In terms of outcomes, unfortunately, there's no data specific for those patients. And again, that's where this large registry, international registry, will help if we're able to put all the patients around the world, or as many as possible, to increase kind of the data that we get. Someone would like to, made an important question on the comparison of treatments of HAI, which means hepatic artery infusion pump, versus Y90. And Jarrett mentioned briefly Y90. Y90 is radioembolization, so it's kind of a direct treatment to the tumor that gives constant radiotherapy. There are small beats, versus transplant. And time, what cases could someone do a better fit for one another? So I will say that hepatic artery infusion pump, as you just heard from Sandra, is actually complementary, and we do accept patients. We work very closely with one of the programs in the city that does use hepatic artery infusion pump, and in some cases it will be a bridge to transplant. So if you are responding to hepatic artery infusion pump, but you're still not resectable, so they've given you the pump to try and decrease your tumor so they can be taken out, but you're still not, we would be happy to see you, and that wouldn't be a contraindication for the transplant. In terms of the outcomes of hepatic artery infusion pump, we don't use it here in Toronto. We don't have large experience, but there is some data. Currently, hepatic artery infusion pump is mainly a palliative therapy. There hasn't been much data on patients that don't recur or get cured if they can't be resected. Data has been mainly generated by Memorial Sloan Kettering in New York, and there's been some studies outside of New York that haven't been able to prove same results. So, there hasn't been a head-to-head comparison, but at this point, it seems that probably transplant is more of a curative therapy than a hepatic infusion pump, even though this I can't prove with strong data. In terms of Y90, there's very minimal data of Y90. There's actually a recent systematic review on the topic, and Y90 is considered as a palliative therapy, or it's used sometimes to try and grow the side of the liver without tumors to leave you with more than 25% so we can resect it. But it's not a curative therapy or a curative intent therapy at this point. In terms of being a Canadian citizen, you don't have to. We have an international patient program, so you can contact us and we can look into that. In terms of liver metastases from other cancers, unfortunately, the answer is no. And there was 2 examples that were posed in the question and answer. One is breast and one is lung. The reason it's not is because, as I mentioned at the beginning, colorectal cancer drains directly into the liver. So actually, many people believe in a way that actually the liver metastases are not really M1 disease. There's not distant metastasis because it's the drainage. But if you think of a breast or a lung cancer, that's hematogenous, like that's general systemic disease. So we assume that if you have metastasis in your liver, you probably have in other places. And the final question, and I'm running out of time, is if anti-rejection drugs put up a higher risk of recurrence. In theory, yes. However, no study has actually proven that. The Oslo data has actually shown in patients that are treated with chemotherapy and patients that have a transplant and get immunosuppression, the growth of lung nodules is the same, kind of trying to prove that actually this doesn't affect. We try to minimize the immunosuppression and we try to give immunosuppression rejection drugs that actually have anti-cancer effects, but no one really knows if it really poses a higher risk of recurrence.
Thank you, Dr. Sapisochin. I'm mindful of time. Courtney, do we have many questions via Facebook Live?
We have 2 questions from Facebook Live.
Would you like to read them out? And we
Absolutely.
will address those very quickly and mindful of time.
For sure. So this first question is from Noor. Thank you for the informative presentation. It sounds like liver transplant is available as a treatment for very specific stages of liver cancer versus mastectomy. Is it now offered as a standard of care to all eligible patients?
So it is offered as standard of care for patients with hepatocellular carcinoma, primary liver cancer. It is offered as standard of care for patients with hilar cholangiocarcinoma. Again, these are selected patients. For patients with intrahepatic cholangiocarcinoma and for metastases from colorectal cancer, it's offered in a study.
All right, thank you. This last question is from Rochelle. My husband has a history of CRC with many episodes of liver metastases, but currently has no disease. He has mild cirrhosis from chemotherapy and multiple surgeries. Is transplant reasonable for him if he is currently disease-free for almost a year, better than relying on medical and less interventional treatments?
Well, that's a good question. I mean, we will have to assess that in detail. If there's indications for transplant from a cirrhosis point of view, usually we've said we need more time since the cancer has been cured until we can offer a transplant. But again, it's hard to know in a question. We will have to assess the case, but it may be reasonable if there are really indications for transplant due to his cirrhosis.
Thank you. So we've reached the end of our session. I would like to thank our great speakers, Jarrett Singer, Sandra Elhilali, and Dr. Gonzalo Sapisochin. I would also like to thank Courtney Mart and Rob DeSimone for their assistance in putting this event together. If you would like to learn more about liver disease, liver transplant, and living donation, please join us for our free monthly summer series, which is co-presented in collaboration with the Canadian Liver Foundation. We've highlighted 2 of our upcoming sessions. There's a third, and the date will be confirmed very shortly. Please visit us on Eventbrite for details and be sure to register in advance. So thanks again to our speakers for their very informative presentations, and thank you all for joining us on Facebook Live. See you next month.